Before the National Health Service, the hospital was not always the kind of place you would go to get better.
I was so petrified of them. And I imagine that fear was common to everybody.
Forbidding, rudimentary, and reserved for the destitute, hospitals were a last resort.
People tended to be frightened to go to the hospital. The hospital was where you went to die.
But in the decades leading up to the NHS, hospitals would undergo an extraordinary transformation. At the heart of this change was a fierce battle against death and disease, as scientists searched for miracle cures, and weird and wonderful technologies helped breathe new life into old afflictions.
They put your foot in a bowl of water, and they passed a current through your leg, and it made your muscle contract and expand.
Yet change was not limited to science and technology. How the system was run and how it was paid for would sow the seeds for another revolution. This is the story of how access to good hospital healthcare became a right, transforming grim Victorian institutions for the poor into modern centres of medicine for all. November 1918, Armistice Day. Behind the smiles and celebrations, a new enemy far less visible was lurking. It would claim more lives than the trenches of the First World War. Britain's hospitals were helpless against it.
The Spanish flu was pretty much global. There was almost nowhere in the world, I think some part of the Amazon, which escaped completely. But one of the ironies of it was that it tended not to affect babies and the elderly and frail, as most influenza viruses do, but it affected younger people, healthy people. It just seemed a terrible sort of visitation, almost a plague, you know, on top of the slaughter of war.
The flu had arrived in Glasgow in the spring. By the end of the year, 250,000 had perished.
The population was already worn down, and it struck hard. Unfortunately, the hospitals were already busy dealing with war casualties, and there wasn't enough room to deal with all those who needed hospital care.
The epidemic would come to an end, but the flu had exposed a crisis. Across the country, hospitals couldn't cope. No national system existed, so they could only offer a patchwork of services. Some had the latest facilities, others were desperately run down.
So there's a range of hospitals, little hospitals dotted all around the country, very disorganised, tended to be perhaps run by one doctor. And this was very problematic because patients could often receive very poor care in these small hospitals. There was no one overseeing, say for example, surgical procedures. And some doctors went well above their levels of competency and tried operating on patients when they had no reason to do so and no ability to do so. So they were quite dangerous.
How you got into hospital and what kind of treatment you received was a lottery. Most people never even made it into hospital.
I don't know what life expectancy was, but it can't have been very high. Death was a very frequent visitor in those days. And pneumonia was a big thing. You died of pneumonia in those days. If you had an accident, broke your neck, for example, that was it, you were dead.
But a change was taking place, and it began with attempts to overcome one of the period's biggest killers, infectious disease.
You've got lots of childhood diseases, such as scarlet fever, mumps, measles, whooping cough, that are really putting a lot of children into hospital. Some of them were more virulent than they would be today.
With a lack of effective cures and no antibiotics at the doctor's disposal, the only chance of fighting disease was to stop the spread of infection.
There weren't many treatments really available to deal with the infectious diseases. Isolation was the key. They built isolation hospitals, isolation wards, and you kept these people isolated for a time that was regarded safe.
When I was about 9 months, I got scarlet fever, which was fatal in those days. You can imagine the terror. I was taken out, wrapped in a red blanket, carried out and to the fever van, taken to the hospital, put in isolation. My parents could go and see me and look at me through a window, but every patient was given a number. Mine was 1268. My sister says the number is engraved on her heart. And the Evening Gazette would print a list of all the numbers with categories following it, like extremely ill, improving, critically ill. And there was a notice board outside the hospital, and my father would stop his bus and look at the list to see what the condition was. I mean, it was as primitive as that and distant as that.
Most feared of all was tuberculosis. TB mainly affected the lungs and caused 1 in 8 deaths at the start of the century.
The symptoms of tuberculosis are usually bleeding from the lungs, so hemorrhaging, so you would bleed out of your mouth and nose, excessive tiredness, weakness, debility, and it was highly infectious.
Diseases were rife in the big industrial cities, where the poor and undernourished were crammed in damp housing and where the air was polluted with filthy smog.
Before the Clean Air Act, we used to get some dreadful, literally hung in curtains, yellow fogs. Awful. And it was obviously not any good for anybody with a chest condition. And that I had this spot on my lung. They decided that I need to get out of London and arranged for me to go to the sanatorium, which was up here on the Mendips.
The sanatorium, an antidote to the soot and smoke of the city. Once you had TB, it offered the only cure then available: bed rest and the great outdoors.
And the idea was that you had fresh air, plenty of it, and you were surrounded by pines, resins, supposed to be good for you.
In 1924, you have the establishment of the Sunlight League, Lidos, being outside and exposing their bodies to the elements, and this is very good for people. And this follows on within hospital spaces as well. You would rest and you'd lie in a bed, you'd breathe air, and this idea that you would expand your lungs with clean air. So to go to the countryside, to look at trees and hills and things like that was considered very beneficial.
They had the treatment if you needed it, pneumothorax treatment for their, it was a treatment which collapsed the lungs, which allowed that part of the lung that was affected to rest in order to try and heal itself. Some of the girls were there for a year, 2 years. It wasn't a thing that you went there sort of short term. If you were, you were lucky. You'd be perhaps out and about with them walking in the grounds, and then next morning you'd ask where, say, Elizabeth was or something. They said, well, sorry, she died in the night. So you just never knew. They could be there one day and gone the next.
Sanatorium treatment for tuberculosis was free for workers under the National Insurance Scheme. Introduced in 1911 by David Lloyd George and the Liberal government, it was an obligatory health insurance for workers, in return for a deduction from their wages.
It covered them for their primary care, in other words, their access to their GP, and it paid for a certain amount of sickness benefit, so that when they were ill and couldn't earn money, they had some money coming in. However, what National Health Insurance did not do was pay for hospital care.
In fact, access to hospital care was organised in an elaborate but haphazard way, and it wasn't intended for everyone.
Today, I think most people think of the hospital as a place where everyone goes for medical services. But in the past, the hospital really was an institution for the poor.
One of the reasons for this was that the largest hospitals had developed out of primitive infirmaries for sick inmates of the workhouse, a Victorian institution for the poor.
The term workhouse implies that they were actually supposed to carry out labour, and that was things like stone breaking and unpicking ropes to stuff mattresses and so on. So the idea of these institutions originally was that they stigmatised people who resorted to the state for support in poverty.
To cater for its sick inhabitants, each workhouse had formed its own infirmary. Their methods of treatment were rudimentary, to say the least.
Bed sharing was common. You might, have someone with an infectious disease sharing a bed, with some other condition. There were no nurses employed by the workhouse in those days. The nursing was all done by inmates who often were illiterate, so they couldn't read instructions, they couldn't read labels on bottles, they distinguished the medicine by the colour of the contents, and they were often drunk.
Many of these infirmaries had improved during the First World War, but they were now reserved mainly for the long-term sick and elderly, and most of them retained their stigma. Wally Barnes remembers what people thought of the workhouse hospital on Bancroft Road in East London.
Don't go into Bancroft because you'll never come out, not on your own feet. Now that was the attitude of some people. If you go into Bancroft Road, you don't come out on your own 2 feet. What they mean is they carry you out.
The hospital is originally for people who cannot afford a doctor at home, basically. So working class people, very poor people, charitable cases. So people who could not afford to go to the doctor or have a doctor come to their home, which is what the middle classes and certainly the upper classes did.
Well, I got a frightful bad pain in my side one day, and it got worse, so I rang up Dr. Cheetle and said, I think I've got appendicitis. I want you to come and take my appendix out. So he did. He showed up straight away. I was about 13 at the time, and he draped everything in the whole room with white sheets. It was quite marvellous looking, In fact, I think Nancy and a group of friends came round at about the same time, and they thought that we were playing doctors or doing something funny in the nursery, It was actually me having my appendix out.
The doctor would come to do the surgery, attend the home with the patient. They would have to pay for the anaesthetist who would come with the doctor to anaesthetize the patient. And then the surgery would be done on the dining room table. And then the patient would go back to their own bed and recover at home, usually with the aid of a professional nurse who would stay with that person all the time. And the doctor would make daily visits to come and see them to make sure that they were doing okay.
And then he fixed it up in a little jar of alcohol. And so I was frightfully pleased to have it. But Nanny flushed it down the toilet, sort of saying it was a disgusting object.
Yet the future of healthcare would lie neither in the homes of the rich nor in the workhouse infirmaries. but in a completely different kind of hospital, funded by charity. These flagship hospitals stood in complete contrast to the horrors of the workhouse. They were known as voluntary hospitals.
Early ones were, for example, Guy's in London, Addenbrooke's in Cambridge, the Bristol Infirmary. Essentially, they differentiated themselves from the poor law workhouses. They were intended largely for what might have been conceived of as the more respectable poor, working people who, for reasons of illness or accident, were temporarily knocked out of the job market.
Providing for local workers and industry, these hospitals were at the cutting edge of medical care.
Voluntary hospitals were interesting. Doctors were actually unpaid. They were honorary doctors in many cases. They almost always had a large private practice, which was where their income came from. And many voluntary hospitals were also teaching hospitals, and doctors got income from the students they taught. A lot of sort of picking and choosing went on, particularly in the outpatients department. Anybody could pretty much pitch up at a voluntary hospital and get seen. And if you had an interesting case, then you might be taken in for treatment because you would be useful teaching material for the staff.
It also depended on what conditions the practitioners were interested in. There might have been a diabetes clinic at the institution, there might have been some interest in cancer research. But the voluntary hospitals always admitted accidents. So if you were the victim of an accident, run down by a cart in the street, for example, you would often just be picked up and carried into a voluntary hospital, and those emergency treatments would be provided.
One of the reasons, of course, why a lot of people would have seen hospitals, perhaps in the 20s and 30s, was the extremely high incidence of car accidents. Roads were pretty unregulated. Of course, there was no seat belts or breathalyzers or anything like that. And there was a great deal of feeling that it was an Englishman's right to drive as fast as he liked, like Mr. Toad, as, you know, on the wrong side of the road, if you like, honking his horn.
The motor car came along, people started having accidents, serious fractures were appearing. Dad was a surgeon, so somebody who was practical and interested in new ideas was obviously the ideal person at the right time to get started on all this.
Dickens' father, Kenneth Priddy, was one of the first surgeons to focus on orthopaedics, surgery of the bones and joints.
He wanted to specialise in this one thing and make a go of it. And up till then, it was just one little facet of general surgery.
He got his opportunity at one of the main voluntary hospitals, the Bristol Royal Infirmary.
I have a photograph that he took in 1934 when he went there of the splint room. It looks like a scrapyard. And obviously he took that just to show what a joke the sort of approach to treatment was at that time and how he was going to sort it out.
A lot of the surgeons who are taking surgery forward at this time, they have to make their own instruments. So they're innovators. They have to design instruments with long handles, for example.
But new tools and a steady hand were not enough to keep you alive. Unique film of Kenneth Priddy performing a hip operation illustrates how a patient's life or death depended on how long they spent under the knife.
He is showing how to measure up the hip with a special measuring device, and you tape that measuring device onto the patient and you drill a little pin in, and you knock this hollow pin over the guide wire. He uses hydraulic hammers and braces and bits and all sorts of things, and hammers it into place. And then he just gets hold of the leg, and it's still, it's still moving, so he hasn't gone too far. Then he sews it up, and then he pans back to the clock to proudly show it's 12 minutes after he started. The point is that if you can complete this operation in 12 minutes, the patient is much more likely to recover quickly, be mobilised and walking again within a couple of weeks and back to work. And that's what the whole thing is about. The longer you were under a general anaesthetic, the more debilitated you were. And previous to that, people had been laid up for 3 months or something. Well, after that, you can't walk anyway, So the operation may be a complete success, but the patient died or whatever, I mean, it's results that count. He was very much a results man.
The surgeons were certainly seen as formidable figures. Within the hospital, they were treated with a lot of respect, especially by the patients. A lot of patients regarded these people as saviors, and they were, after all, volunteers. They weren't paid for their services, so they were set apart from the paid hospital staff.
We didn't have much dealing with the surgeons. They were very remote. When they came, it was almost sweeping the path in front of them because they were considered so lofty. They were thought so highly of, Mr. this, Doctor that, yes. They were next to God, really, in many ways.
They were consultants. They had large private practices by this time. And although these were charitable cases, grateful patients often brought their surgeons gifts in exchange for some of the surgery that was performed.
Voluntary hospitals had been set up as charitable institutions, but the foundations on which they'd been built were crumbling. Britain's economy had not recovered after the war, and it wasn't just the poor who were feeling the pinch.
It's sometimes summed up as death, duty, and death duties. In other words, the very rich classes in Britain who had been a linchpin of providing charity for the voluntary hospitals had actually not only suffered quite significant losses of younger sons who'd gone off as officers to fight in the trenches and so on, so families had actually been hit quite badly, but they were now having to pay much larger levels of taxation. This was the moment in which charity, the old traditional forms of hospital philanthropy, now began to seem inadequate.
With rising costs, voluntary hospitals were desperately strapped for cash. A dramatic change was needed in how they were paid for. The solution was to hit the streets. Flag Day was born.
They were very important. They were usually instigated by somebody notable. One of the best ones I remember, which doesn't exist anymore, was she was their great patron, was Queen Alexandra, and it was known as Alexandra Rose Day. They were like a little dog rose that grows in the hedge, and they were produced, and you bought your rose, put your money in your collecting tin. Shops would sell them. Everybody bought. They didn't pass anybody by. I can't remember anybody not buying an Alexandra rose.
The new forms of charity were tapping into a vein of frivolity and hedonism in post-war society.
There was the feeling that in the 20s and 30s that somehow if you're having fun and drinking rather a lot and dressing up, but the money is going to a good cause, and hospitals were regarded somehow as politically unproblematic and a good cause, and so it fitted in quite well with any sort of hedonism there was around.
have bazaars, you have dances, you have an egg week. It might seem insignificant, but one hospital might collect 100,000 eggs, and that would feed a lot of patients. Other innovative schemes included the Linen League, where a small hospital might get all of the clothes for patients, all of the sheets made by local charities.
Charity had moved from endowments to pennies from the community. But rag weeks and carnivals weren't enough to meet the spiralling costs of running a hospital. More and more, they were forced to turn to contributions from the patients themselves.
Voluntary hospitals almost always were short of money. And as time went on, there was a greater expectation and demand on patients who could pay that they would pay.
They started to introduce small-scale charges, user fees for ordinary people. It wasn't anything like the full cost of treatment, but it was a payment which was assessed, means-tested really, on the basis of a person's income. And it led to the arrival of a new figure within the hospital almoner. And the almoner would conduct an interview with the patients and assess what sort of payment they would be able to make.
The lady almoner would come round to me father and say, well, you know, you've got to pay. So there was no fixed fee. You know, you've got to pay. So you say, well, I haven't got that money. What are you going to do to me? So you say, well, you know, what can you afford? So he used to push him, and if he had money on him, you know, if he had money, he would pay, say, I'll give you £5 bob. You know, the lady almoner would say, that's all you could afford, £5 bob? Okay, you know, that was the fee. But if you was well off, you paid more, you know, it was according to what you was.
The need to pay had given rise to new forms of insurance schemes based on contributions.
The other big development of this period was the development of large-scale contributory schemes pitched at the working-class patient. And these usually actually were run through the workplace, the factory, the shop, whatever. And the way it worked is that a small amount of money would be deducted from people's wages. Sometimes it was a penny in the pound of their earnings, and sometimes it was just a set amount of a few pence on a regular basis.
The 1920s saw a mushrooming of these schemes around the country, and they grew rapidly. Membership of a scheme would typically cover the family for some hospital services, but it was based on how much you earned and what kind of medical conditions you had. Some schemes were organised by the hospitals themselves. Others were run by independent organisations. It was the almoner's job to work out who was covered.
And my task was to assess people in terms of their ability to meet the costs of having prescribed treatment. I would put the category into which they fell, and if they were to have free treatment, there was a large F, and if they were belonging to a scheme which gave them free hospital treatment, like the Hospital Savings Association, I would put HSA. And if they were feeling they would like to contribute and were in a position to contribute, then there would be a D, a donation.
A rigorous assessment of the patient's finances could come at the expense of compassion for their needs.
You see, a lady almoner, and she used to ask you just what money you could afford to pay. She wanted a lot at first. I said, well, I can't afford that because naturally we've got to get some clothes for the baby, you know, when it's born and things. Anyway, when the baby was born dead, a couple of days after, she came up to me in the ward. This is their attitude of caring. And she said to me, well, now you've lost your baby, you haven't got a baby, perhaps you can pay more money.
Originally, the almoner was appointed to investigate the financial backgrounds of the patients. Could they pay for treatment? This is how they're remembered, but they did a lot more. They very quickly became a clearinghouse for the hospital. They identified patients who needed additional support within the community, whether it was educational, They needed help finding work. They needed help feeding children. Their role started to expand, and eventually they developed into the modern social worker.
The almoner was the great go-between dealing with the social side of the patients, and that was well done. If a patient died, she was the person who dealt with all the arrangements of death and so on. And as a houseman, as a doctor, we just had never been taught, and we didn't know how to do it, and we didn't do it. And so, to me, an almoner was a very valuable person in the team that we belonged to.
William Frankland was a junior doctor in the casualty department at St Mary's Hospital, London, in the early 30s.
Before the antibiotic era, there were so many diseases that we really could help very little compared with what you could help now. And so the patients would be in for a very long time.
Protecting patients from the risks of infection was essential. Mary Allen trained as a nurse in the 1930s and had to use careful nursing to guard against it.
There were always two nurses. One they called the dirty nurse and the clean nurse. The dirty nurse always took the dirty dressings off and all, and disposed of those. And then the clean nurse opened her sterile packet and was able to get on with the dressing, but she never touched anything that was soiled.
Locked inside the hospital walls, a different fight was taking place against the bacteria which caused infection. William Frankland worked with a scientist at the forefront of the quest to find new such cures. His name was Alexander Fleming.
Fleming was, I had to see him every day at 10 o'clock in the morning. Theoretically, to talk about the patients in the ward, we had this experimental ward. This wasn't the people with all sorts of rare diseases, and could we help them, and could Fleming help them, and could anyone else help them? And one of my jobs was to look after them. But so I had to report to Fleming every morning at 10 o'clock. He wasn't interested in patients. In 2 years, I can only remember him once asking him about a patient. He was always interested in getting a substance which would deal with infection. And I remember very well, he talked about the mold, Penicillium notatum it was called, this green mold.
The consequences of this discovery would not be felt for another decade. But before penicillin, another medication had already arrived on the scene. The new sulfonamide-based drugs were effective against puerperal fever, a common bacterial infection contracted by women during childbirth.
As a student, we were taken to Queen Charlotte's Hospital to see women who got puerperal sepsis, that's an infection with a high swinging fever, with a high mortality. And they were put on this amazing drug. Down came the temperature. And we were seeing something absolutely unbelievable. So here was the first, the word antibiotic actually wasn't coined until 1950, so we'll call it an antibacterial, used. And that was absolutely dramatic.
The introduction of sulfonamide saw maternal deaths nosedive. In the next 15 years, they would fall by 80%. This was part of a change, which saw women giving birth in hospitals for the first time. Hospitals were seen as safer environments, freer from infection, offering the best of medical science. And other discoveries were being made elsewhere in hospitals. Scientists were exploring all sorts of bizarre and creative ways for tackling some of the most lethal conditions. These included the invention of arcane pieces of equipment for artificial respiration.
There was one called the Curious. It was an arrangement, it was a bit like the old Roman soldiers, I suppose. It was like a back and front metallic front. They were sandwiched in between this piece of equipment. They was attached to bellows. They could wear the cuirass and that would be attached to the equipment. They could go on the back of a wheelchair.
But the most groundbreaking of them emerged in the United States in 1928. Its name would endure for decades to come. They called it the iron lung.
I think what is interesting about iron lungs is they are iconic pieces of medical technology because they do save life. It's a savior for this terrible scourge of polio that is terrifying the nation.
His name is Johnny Green, and he's 2 years old. He looks well enough, but there is something wrong with him. He has had infantile paralysis, or to give it its proper name, poliomyelitis.
Polio was a virus which attacked the central nervous system and disabled the muscles it infected. Also known as infantile paralysis, it mainly affected children.
Polio was a really big thing there, and it seemed to be spread like wildfire. And they said it was spread from swimming pools and things like that. And I do know people, there were kids who wore calipers on their legs as a result of having polio.
At its worst, polio paralyzed lung muscles and stopped patients breathing normally. Before a vaccine was available, the iron lung was the only way to keep people alive once they had the disease. It was the world's first life support machine.
Basically, the iron lung is what they call a negative pressure chamber. And what it does is it pressurizes and depressurizes the patient's chest. Some people never got out of their iron lung. Some people did get out of their iron lungs and they were used only temporarily. The nursing staff would take the patient out for a few minutes and gradually build a patient up till they were breathing on their own. It is an incredibly complex piece of medical technology, therefore it is very expensive.
With hospitals unable to afford them, getting access to an iron lung was not easy. But in 1937, an Australian scientist named Edward Both came up with a cheaper alternative. It was made from plywood and immediately drew the attention of car manufacturer William Morris, also known as Lord Nuffield. He offered to construct thousands of them in his factory for free.
I sincerely hope that my gift will be the means of saving many valuable lives.
Hospital treatment was becoming increasingly dependent on medical technologies. UV light treatment for vitamin D deficiency was a common therapy, as was the use of electricity.
I had to have a treatment called Faradism. Sounds awful, but it wasn't too bad. It was a form of electricity that I think they can't job to remember it now, but they put your foot in a bowl of water and they passed a current through your leg and it made your muscle contract and expand. So it tried to build up your muscle tone. It did make it. It wasn't particularly comfortable, but they could start the electricity, at a lower level and gradually turn it up a little bit.
One critical invention was the introduction of radium therapy for treating cancer.
Radium is the crown jewel in the ray-based therapies that begin to emerge in the 20th century. Cancer cases are increasing, and it seems to be one potential cure. The problem is that radium is quite expensive, at about £15,000 a gram at the time. A lot of hospitals are struggling to pay their ordinary bills. Here's this new therapeutic agent which they need some help buying.
To fund these new technologies, hospitals were still dependent on raising money through charitable organisations. One of the largest was the King Edward's Fund. This model hospital, now at the Science Museum, was built as a promotional tool by the fund in 1932. Throughout the decade, it toured the country and was seen by hundreds of thousands of people. It was an illustration of how hospitals have been transformed. Now centres of medical expertise, they offered a more attractive, sophisticated environment to receive treatment.
With this rise in technology, people feel a lot more comfortable about going to hospital, in that it is a safer, scientific environment. They get diagnosed, they get looked after. Middle-class people see this as being able to get the best care, and they want to get the best care as well.
The rise in middle-class patients gave voluntary hospitals a chance to tap into some vital new income.
The response was to begin to open either pay beds or private wards, or in some cases private wings, separate wings of the hospital.
And one of the great things was, if you were a private patient, you wouldn't be taught on by horrible medical students, which was a pity because there was a lot of very good clinical material there. But no, the private patients, and some people I think insured themselves to make sure exactly the place they went to privately, and they would have a single room. They'd have much more nurses to look after them, but they wouldn't have these medical students or be taught on or practice on and so on.
So hospitals become a more pleasant place to go, and we see lovely painted walls, lights above the bed, reading material, the buzzer. Conversely, visiting hours could still be quite draconian, even though hospitals were much more pleasant. For example, visiting children in hospital was still quite rigidly controlled throughout the 1930s. And say, for example, at an orthopedic hospital, children under 12 who are in the hospital were only able to be visited twice a month on a Sunday for 2 hours.
But getting into hospital at all was becoming harder. As they moved away from charity and towards a paid-for service, hospitals were struggling to meet the new demand.
One of the problems of the hospital was the success that they were having. A lot of people wanted to get into them. They saw them as the right place to get medical treatment. So the 1920s and 30s, you see the rise of waiting lists. Not dozens of people, but hundreds of people.
The patients themselves always hoped that they would go to the well-known hospital, which would have a medical school attached to it, and they would have the well-known consultants attached to that hospital.
In fact, voluntary hospitals only provided a third of the total beds across the country. The majority was still to be found in the old workhouse infirmaries, mainly reserved for the long-term sick and the elderly. Bella Aronovich was moved to one following an appendix operation which wouldn't heal.
I was, I suppose, about 18 when I was transferred to this poor low hospital. I'd been in the voluntary hospitals up to then and got a kind of set picture of what they were like, and I looked round and there were numbers and no names on the ward, and when the door was opened and I looked at this sea of faces, I felt indescribably frightened and really low. I hadn't expected anything like this. The beds were so close together that you could touch the patient in the next bed.
The names of the wards were Faith, Hope and Charity. Everything about it was so run down, it was so poverty-stricken, and there was such an atmosphere of death there.
All the time I was in hospital, I used to think, well, fancy leaving the health to millions of people in this ad hoc way, when some people could pretty well get all that they wanted, and for the others it was one long struggle.
But a new piece of legislation in 1929 would allow local councils to take over the running of these old institutions. They became known as municipal hospitals, and London was leading the way.
On the 1st of April 1930, the London County Council appropriated all the hospitals it had inherited, both from the London workhouses and also from the Metropolitan Asylums Board. Overnight, they had on their hands 98 hospitals, which they set about trying to organise into a coherent system.
What they tried to do essentially was upgrade the poor law infirmaries, the workhouse infirmaries, and turn them into potential competitors with the voluntary hospitals, giving them operating theatres, introducing all the new technologies and therapies that are available at the voluntary hospitals.
In Glasgow, the council took over Stobwell Hospital, an old workhouse infirmary. This film was made to publicise its newly modernised facilities. Yet places like Glasgow and London were exceptions. In many parts of the country, workhouse infirmaries were not taken over, and even if they were, they couldn't shake off their notorious reputations.
A lot of people didn't want to go into these institutions even after they were handed over to the municipal authorities. On children's birth certificates, for example, those children who were born in some of these institutions, they simply put an address, not the name of the institution, because the stigma was still very strong.
Despite improvements in particular areas, the quality of hospitals varied greatly depending on where you lived and how much you could afford to pay.
A third of all specialists lived in London. So London was the place to go if you wanted to specialise in particular areas of medicine. And consultants could make a lot of money. And there was a lot of resentment about their high-handed attitude or the fact that they weren't really caring for people who were very, very ill. They were just caring for people who could pay.
There was this tension all the time between the requirements of doctors. Doctors were always really keen to preserve their private practice. The voluntary hospitals were always desperate to preserve their independence, and the municipal hospitals really wanted more and more to become the general provider for the citizens. It really was in desperate need of bringing together into some coherent shape.
The lack of a joined-up hospital system ran counter to one of the big ideas that was animating Britain at the time.
One of the great words of the 30s was planning. There were all sorts of organisations which were just devoted to planning, that you found out all you could about a subject, be it transport, be it medicine, and then on the basis of information you laid your plans and your recommendations and you formulated your policy. That was very true in health towards the end of the 30s.
Eventually, a debate would be launched about how a new hospital system might be organised. But another crisis loomed, which presented the hospitals with an even greater, more immediate challenge. War.
The First World War was not very organised. It kind of happened. Whereas the Second World War, the country was preparing. In 1937, the emergency medical services was set up. So that was 2 years before the war was even declared.
In the towns, the front line of modern war, the health services were organised to deal with the menace of air attack. The voluntary and municipal hospitals were linked together under one national health service. Taking the London area as an example, what has happened is this. The area has been divided into sectors, each with one of the big hospitals acting as parent.
Across the country, the emergency medical service took control of hospitals and placed them under one umbrella. New wards were built and temporary buildings set up. 50,000 hospital beds were added in just a few months. Doctors were employed by the service and sent to where they were most needed. The emergency medical service had set an example of how an integrated hospital system could be run.
It provided a model for the planners who, during the Second World War, were beginning to think much more seriously about the possibility of a national health service. This is when the term first starts to be introduced, in the sense of delivering a more comprehensive service and indeed a universal service, something to which everybody had access simply by right of citizenship.
What the Second World War did, of course, was to emphasise that health could no longer be left to philanthropy, could no longer be left to voluntary initiatives and good-hearted ladies selling flags. It was the health of the nation, and the nation or the government needed to take responsibility for it. You know, the health of the nation was too important to be left to these hodgepodge of arrangements.
In the old days, money meant a well-planned entry into the world with as much skill and care as a Harley Street nursing home could provide. But in the new world that we are making, and making in the very teeth of war, we give every baby the right to both the broad acres and the Harley Street skill.
The idea that citizens had a right to hospital care was crystallized by the experience of war. But war had also accelerated the development of earlier scientific discoveries. It had taken over a decade to be purified and manufactured, but Fleming's mould had finally arrived. It was called penicillin.
When it was introduced to the wards for use on patients, it was literally kept under lock and key. It was so precious that it was only the senior staff that were allowed the keys to go and get it out and draw up the doses and go and give it to the patients, and we were absolutely astounded. It was literally a miracle drug.
Jim Mulligan was one of the first civilians to receive penicillin when he went into hospital for an operation.
I was due to be in there for several weeks, if not months, and they used penicillin on me, and it was one of the first times that it was used on civilians, because it was developed for soldiers in the war. And I was out in 3 weeks. In that time I saw my first banana. And on one day my brother brought in the Daily Mirror with the headline about this amazing bomb that they've dropped in Japan, and it'll do this and it'll do that. And that was I remember seeing the Daily Mirror with the Hiroshima bomb.
In 1945, Britons were celebrating the end of another war. The First World War had ended without a proper hospital system. The Second World War would help provide one.
After the First World War, everything went back to the way it was. Whereas in the Second World War, people did not want that to happen again. They had suffered, they'd lost family, friends. They wanted things to change. So this idea of never again is extremely important, and it has a lot of importance towards the formation of the NHS.
The change in mood had brought a newly elected Labour government. Riding on a wave of public support, it began immediately to implement plans for a new national health service.
But suppose instead of a simple broken leg, you have a complicated break. And suppose you have to spend months off sick. And suppose you don't need just one doctor, but a number of experts' opinions. What's the answer to that?
Ruin.
With this new act, you're covered against things like that.
Despite huge support for a unified service, the government faced opposition from the medical profession. A fierce debate raged between them and the British Medical Association. Key to the disagreement was the prospect of a state-salaried medical service. Some consultants were reluctant to give up their lucrative private practices and suspicious of the state undermining their independence. But the new Minister of Health came up with a solution which would bring them on board.
It was Nye Bevan who inaugurated the National Health Service. I think he once said that he'd filled the doctors' mouths with gold to persuade them to go with the new system.
Bevan's gold meant doctors could still hold on to their private practices even though they were employed by the state. The government could now push forward with the new legislation.
On July 5th, the new National Health Service starts, providing hospital and specialist services, medicines, drugs and appliances, care of the teeth and eyes.
I remember everybody being absolutely delighted because all those fears and the trepidation and the knowing that if you got ill, that was serious and you just had to manage it on your own. It changed completely. It was a different world.
It was the dawn of a new age. But it hadn't emerged from nowhere. This had been a long revolution, built on decades of innovation in which the hospital had played a central role. Pioneering research and technologies had reduced deaths and generated a new faith in medical science. Hospitals had opened their doors to the community to raise funds, but they had also raised expectations of entitlement to treatment. United in war, the hospitals had laid the foundations of a new system which for the first time in history would provide healthcare for all. Free at the point of service, from cradle to grave.